Hello everyone, in today's topic I'll be talking about the plasma cell disorder. What are plasma cells, where they are derived from, and what is the appearance of a plasma cell, what are the tumors of the plasma cell, mainly the multiple myeloma. I'll be discussing the pathophysiology of multiple myeloma, the clinical features, investigation and the treatment. So guys, watch the entire video as I'll be discussing why do we see anemia in multiple myeloma, why there is a raised ASR, why there is increased chance of AL type of amyloidosis, why they have rouleau formation in the peripheral blood smear and how to differentiate it from the cholangitis, and why there isn't hypercalcemia, and why we treat multiple myeloma with the proteasome inhibitor. Okay. So guys, if my videos are helping you, then please like, share and subscribe. Okay. So talking about the plasma cell, it is mainly derived from the B lymphocyte, which is derived from the lymphoblast from the hematopoietic stem cells in the bone marrow, and they produce the antibodies which is mainly responsible to prevent infection. And normally in the bone marrow we see less than 5% of plasma cells in the marrow. Okay. And the appearance of a plasma cell, it is an oval cell with abundant cytoplasm, and the nucleus is in the periphery, that's an eccentric nucleus with a clock phase chromatin, and around the nucleus this is the perinuclear area, that's mainly for the Golgi apparatus. So coming to the plasma cell dyscrasia, it is a plasma cell is a there is a neoplastic proliferation of the plasma cell. As a result, there is an excess production of the monoclonal proteins. So normally, as we can see, this is the bone, and inside the bone we have the bone marrow, and they have the hematopoietic stem cells in the marrow. They have less than 5% of plasma cells in the bone marrow. Okay, but in multiple myeloma, they have more than 10% of plasma cells in the bone marrow to diagnose it as a multiple myeloma. So coming to the pathophysiology, myeloma cells, they produce abnormal immunoglobulins, okay, abnormal immunoglobulins or fragments of those immunoglobulins which are called the light chain. So in the bone marrow, when there is a hematopoietic stem cells, those cells, because this is a tumor and the plasma cells are proliferating, and we call it multiple myeloma when we see more than 10% plasma cells in the bone marrow. So when these plasma cells are proliferating, they are producing immunoglobulins, and those are the abnormal immunoglobulins, mainly the IgG and the IgA and the light chain, which are nothing but the fragments of the immunoglobulins. So now we'll see why there is a hypercalcemia and bone pain in multiple myeloma. Normally what happens, the osteoblast is on the surface of the osteoblast there is a rank curve, and on the surface of the osteoclast there is a rank, and the osteoprotozoary which is derived from the osteoblast, so it prevents the interaction of rank L with the rank, so there is no osteoclastic activation. But in case of multiple myeloma, what happens, those myeloma cells will stimulate the maturation of the osteoclast by forming rank L and inhibiting the OPG. So that means when the OPG is inhibited, then there is more interaction of rank L with the rank, and there is uh, more maturation of the osteoclast. Okay. Another important mechanism is that these myeloma cells, they release cytokines, mainly the IL-3 and IL-7, and that will inhibit the osteoblastic activity and stimulate the osteoclast and cause osteolytic bone destruction. As a result, there is release of calcium from the bone, causing hypercalcemia and bone pain. Okay. Coming to the clinical features, they are in multiple myeloma, they have normocytic normochromic anemia. Why there is a normocytic normochromic anemia? The reason is that these neoplastic plasma cells, when they are proliferating in the bone marrow, they are suppressing the erythroid series of cells, leading to anemia. And as we already discussed that when the calcium is released from the bone, the patient will complain of bone pain. And when you do the skull X-ray, you can see that there is a lytic construct lesions. Okay, and while the patients with the multiple myeloma, the risk of infection is increased. Normally what happens, the plasma cells, they produce antibodies, those are effective for preventing infection, But the neoplastic plasma cells, they are producing abnormal antibodies, and they are not decreasing. No, they are not decreasing the infection. As a result, the risk of infection is increased. Okay. In the peripheral blood smear, you will see the RBCs. They may have anemia. You can see the pallor, okay, and inside the RBC, and there is a rouleau formation where the RBCs are stacked one over another like coins, and those are called the rouleau formation. Normally, what happens? The RBCs on the surface, they are negatively charged. As a result, one RBC cannot get attached to another RBC because they repel each other. But in case of multiple myeloma, these proteins, they decrease the negative charge. As a result, the RBCs get stick to one another, forming the rouleau formation, and this should be differentiated from the cold agglutinin, where there is a agglutination of the RBC instead of this rouleau formation, and in cold agglutinin is mainly due to the mycoplasma infection, okay, or mainly mycoplasma infection. You see the cold agglutinin, and where there is an agglutination of the RBC. And now, since these RBCs are sticking to one another, there is a high chance that the RBCs are settling faster, and that is why the erythrocyte sedimentation rate is increased in multiple myeloma. Okay, and why there is a renal failure in multiple myeloma? Multiple myeloma cells, they produce monoclonal immunoglobulins, okay, and they block the renal tubules, leading to light chain cast nephropathy. So these light chains, they block the tubules and cause nephropathy, okay, and there is also increase in the 24-hour urinary protein, and when the tubules are blocked, they will lead to renal failure. And normally the erythropoietin is released from the kidney, but in renal failure the erythropoietin is reduced and not able to stimulate the bone marrow to produce RBC, and that will lead to anemia. As we know that the erythropoietin is produced by the kidney, which stimulates the bone marrow to produce the erythroid series of cells. But in renal failure, the erythropoietin is decreased, leading to anemia. And while there is an AL type of amyloidosis, in multiple myeloma, these light chains, they form insoluble fibrils, okay, and they get deposited in the tissue, and that will lead to AL type of amyloidosis. Okay. Now coming to the investigation and the management. The investigation we do is serum and urine electrophoresis. In this, normally we see that the albumin has a peak with alpha 1, alpha 2, beta and gamma. You can see the gamma is not that big normally, but in case of multiple myeloma, because there is a monoclonal proliferation of these immunoglobulins, the M spike is very prominent. Okay, this M spike can be seen in Waldenstrom's macroglobulinemia, which I will be discussing in the part 2 of the video, guys. This is the part 1 video. In part 2, I will talk about Waldenstrom's macroglobulinemia and monoclonal gammopathy of undetermined significance. Okay, and when you do a bone marrow aspiration, you will see more than 10% of plasma cell, and bone marrow biopsy is confirmatory for multiple myeloma. And of course, when you do the skeletal X-ray, you would see the osteolytic bone lesions. And what is the treatment we give? We give proteasome. This is a drug which will inhibit the proteasome, and this drug causes apoptosis of the multiple myeloma cells. So hence it is effective in multiple myeloma. So guys, with this, I hope that this video helped you, and I'm hoping that you will be watching the part 2 of the video. Okay guys, so thank you and take care.